Hello everyone. Our talk today is about the different management option in patient with tricuspid valve endocarditis, and here is our agenda for today. The incidence of tricuspid valve endocarditis is increasing during the last decade, approaching 10% of all cases of endocarditis and even higher. Staph aureus is a predominant organism in such patient, with most cases are methicillin resistant Staph aureus, about 90% of cases. The usual presentation is multiple septic pulmonary emboli causing multiple ischemic lung abscesses, which is commonly misdiagnosed as chest infection and lately referred for cardiologist opinion. Less commonly present with right-sided heart failure manifestation due to severe tricuspid valve damage causing severe tricuspid regurgitation or obstruction by large vegetation. Vegetation size with size more than 2 cm, fungal etiology are the main predictor of this in such patient. Importantly, there is a main obstacle in management of IV drug abuser, which is the re-addiction reinfection circle. So a multidisciplinary team approach with addiction specialist as a cornerstone of this team is mandatory in management of this cohort of patients. Importantly, some of these patients refuse to stay for the whole 4 to 6 weeks course of antibiotic inside the hospital. In these circumstances, we have one of two options. If the patient is clinically stable, he might be discharged on oral antibiotic regimen, or if he is in need for continuation of IV antibiotic. So we have a novel options with a long-acting antibiotic with once weekly regimen, namely dalbavancin and oritavancin. So when to intervene in such a patient? Intervention is needed in about 25% of cases. The main indication are resistant infection defined by persistence of bacteremia for more than 7 days despite adequate antimicrobial treatment. Second indication is recurrent lung showers associated with large vegetation more than 2 cm. The third indication is resistant heart failure with poor response to diuretic therapy. As we noticed here, all these recommendations carry a level of evidence C, which means that it is mainly obtained from expert opinion or non-randomized data. So we have multiple challenges on surgery in such a patient. First is the high recurrence rate of infective endocarditis due to continued drug abuse, reaching about 25% of cases, leading to reinfection. Second is we have a limited option in surgery because mechanical prosthesis thrombosis is about 20 times the left-sided one due to low flow across the tricuspid valve. So we are left with either tricuspid valve replacement with tissue prosthesis, which has a questionable durability, ranging between 7 years up to 14 years durability. And most cohort of IV drug abuser are young, so the need of re-intervention is high as shown here. So in daily practice, there is a more conservative approach. So if we have 25% of cases in need for intervention, less than 5% actually are referred for surgery. So what is the alternative option? The alternative surgical option are tricuspid valve repair, with either removal of the vegetation with patch repair, or if there is extensive damage of the one of the tricuspid valve leaflet, so excision of the whole leaflet with bicuspidization of the valve are done. But unfortunately, the data about tricuspid valve repair are limited and mostly reported from single centers. So we have a novel solution for such a problem, percutaneous aspiration of vegetation or remove the nest strategy. What is the potential benefits of this option? When removing the nest or the vegetation, we have one of these benefits. lessen the microbial burden by removing the nest of organisms, disruption of the fibrotic vegetation cap, so we have more surface area for antimicrobial work, decrease the chance of further showering because we are removing the vegetation itself, and it might improve the valve leaflet dynamics, improving tricuspid regurg in some cases. So if you remember, these are the main 3 indications for intervention. So if we have a magic solution of getting rid of the organism, lessen the risk for showering, improving tricuspid regurg, so this will be the future for tricuspid valve endocarditis management. To achieve this, we have what is called the Angiovac aspiration system. It is a large bore system requiring 26 French tri-seal sheaths introduced through the internal jugular vein. Through it, an Angiovac catheter, which is a 22 French catheter. The third generation of this catheter is self-expandable nitinol funnel-shaped tip to engage easily the vegetation. The suction power is driven through an extracorporeal machine like that of ECMO, connected to the catheter with intervening filter to filter the aspirated vegetation. Then reinfusion of the aspirated blood again into the patient is done via a venous bypass circuit, which is a standard one, either to the contralateral internal jugular vein or one of the femoral veins. So after introducing the catheter through the sheath, reaching appropriate site, guided by transesophageal echo or intracardiac echocardiogram, then the machine is activated with suction power between 2 to 3 liters per minute. Then the vegetation is aspirated and trapped inside the filter, and the blood re-infused again, as we said, into the contralateral jugular or one of the femoral veins. And here is one of the cases reported in the literature. The first generation of this catheter was a straight tip and balloon inflated tip. The second generation has a 20-degree angulation. The third generation is a self-expandable nitinol one with 180-degree angle movements. We have a different reperfusion options for the aspirated blood. The standard one is venous bypass, which simply reinfuse the aspirated blood to the contralateral jugular vein or one of the femoral veins. If the patient has marked lung affection, either due to pyemic showers or ARDS, then we can integrate an oxygenator in this circuit, converting it into a venous ECMO-like configuration. If the patient has LV dysfunction or RV dysfunction, then we can reinfuse the blood into the artery directly, taking a configuration of venous arterial ECMO. Some technical points is calculating the angle between the catheter here entering from the SPC and the vegetation is very important to catch the vegetation easily without any potential risk of showering. This actually calculated using TE or intracardiac echocardiogram. And importantly, the clockwise torque of the Angiovac catheter produce a counterclock rotation of the catheter in the TE image. So what about the result? The reported technical success result in different centers reaching about 90%, defined by debulking more than 80% of the vegetation size without complications. On the term of microbial eradication, the resolution of bacteremia within 48 hours have reported in about 75% of cases. Regarding tricuspid regurgitation, it was stationary in about 60% of cases. Improved leaflet dynamics and improved tricuspid regurg reported in 20%, and worsened tricuspid regurgitation due to suction of vegetation that occluding a perforation or closing a malcoaption defect reported in about 20% of cases. And here is an example of one of the Angiovac cases from Stuker et al. In the literature. Here is the Angiovac catheter introduced through the superior vena cava, catching the vegetation, and here's the picture after aspiration. So recently we have a novel system that doesn't need extracorporeal circuit and depend only on controlled manual aspiration using a 50 cc syringe system that called the flow retriever system from Inari, and we have also the Alphavac system from Angiodynamic. After gaining access through 24 French sheaths, then the Inari or flow retriever catheter introduced, which is 20 French curved catheter. The curve can be modified up to 260 degree angulation by pulling or pushing the overlying sheath, leading to modification of the angle of the tip, and guided by either intracardiac echocardiogram like this case from Dr. Abdelkader Al-Manfi, or might be guided by TE. And here is a picture of the vegetation after aspiration. The potential benefit of this system over the Angiovac system is being less invasive with less blood loss. It doesn't require cardiopulmonary bypass, and as we mentioned, the curved catheter tip has an options for changing the angle of the tip up to 260 degree. The future options are to treat the residual regurgitation after debulking of the vegetation using one of these percutaneous option, either treating the malcoaption using Triclip, or valve replacement in orthopic position using LOX valve, or in heterotropic caval position using the Trich valve. But all these options are not yet reported in the literature, so we have no evidence to use any of them in the circumstances of acute endocarditis. To sum up, multidisciplinary team approach with an addiction medicine specialist is mandatory to break the circuit of addiction reinfection. The indication of intervention with surgery or intervention are either resistant infection, resistant showering, resistant heart failure. Surgical options are limited between tricuspid valve repair or tissue valve replacement. And we have the novel solutions of aspiration vasectomy using the Angiovac system or the recent controlled manual suction flow retriever Inari or Alphavac system. And finally, thank you.